Hello everyone! Welcome to another webinar from the Steps Forward Innovation Academy. Today is the first in a 5-part series focused on value-based care. Today's topic is enhancing value-based care with technology. And over the next 45 minutes, we will delve into the latest strategies and opportunities for how technology solutions can help transform care and better enable success in value-based care arrangements. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult with a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA.
Thank you so much and welcome everybody. I'm your moderator today, Chris Bond, Senior Manager of Care Delivery and Payment here at the AMA. It's my pleasure to introduce today's speakers, both of whom are members of AMA's Health System Program. Joining us today are Dr. Bryan Batson, CEO at Hattiesburg Clinic, and Dr. Narayana Murali, CMO of Medicine Services at Geisinger Health. Upon conclusion of today's discussion, you'll be able to understand key strategies for leveraging technology, identifying proven and promising strategies for easing and overcoming barriers to digitally enabled value-based care, and outlining future opportunities for continued digitally enabled innovations for value-based care. So with that, I'll pass the virtual mic over to you, Dr. Batson.
Thank you, Chris. I'm glad to be here today. Actually, I don't see that the slides are up yet, so I may need a little help seeing that. Just a sec. There we go. Okay. All right. Just a little bit about Hattiesburg Clinic. Again, I'm Bryan Batson, CEO of Hattiesburg Clinic. Next slide. A little bit about us. We are a 62-year-old organization. We're independent, still physician-owned and governed, and located in the southeastern United States with about 500 providers, 300 of which are physicians and 200 or so advanced practice providers, spanning 40 specialties in 17 counties with about 2,500 employees. I'll note on the right, because this is really about a technology presentation, things that Hattiesburg Clinic has chosen to invest in have really helped pave our way in value-based care. And to that end, we are in stage 7 organization as well as Epic Gold Stars 10. Forbes magazine ranked us the best place to work in Mississippi in 2022, and we're glad to participate in the AMA's Joy of Medicine program, most recently being rewarded a bronze reward. And I think the technology piece and physician wellness and happiness play integral roles in value-based care. Next slide. As I noted, the quadruple aim is something we very much believe in Hattiesburg Clinic, a step beyond the triple aim of high quality, low cost care and patient satisfaction. But value-based care and physician wellness are very tied together, we believe. And in order for physicians and other members of the care team to provide the highest quality care in the lowest cost environment with patient satisfaction, those care team members need to be satisfied in their work environment. And we believe that technology plays a big role in that as well. Next slide. So we have several tools. I won't go through each of them. I think the point in this slide is to really point out that the things that are out there, we've tried to leverage and use to provide some transparency and visibility into quality and cost. We, of course, use multiple risk calculators as part of our workflows in the clinical and operations and quality management space. We use a significant amount of risk adjustment support and risk adjustment coding tools to help us make sure we're doing appropriate risk capture of our value-based care patients. We have the kind of many building blocks of some of these tools, such as the disease registries and analytics catalogs. And then for physicians and other members of the care team to have full visibility into how well we're doing. Of course, dashboards are really crucial to that, and reporting tools, and then clinical decision support for the clinicians, and then those patient-facing tools. I'll make the point here that it's a lot of tools, it's a lot of technology, but really crucial to our view of how to make the best use of technology is really marrying those tools to the operational and clinical workflows and incorporating the technology team into the operations and clinical teams very early in the process for any one of these tools, so that we can make sure that we're building tools and using tools that are not in a silo, but are really built with the view of how do we use them in value-based care in the clinical space. Next slide. I'm going to go through a couple of workflows that are really specific to value-based care. I believe many people on the call today are familiar with the chronic care management workflows, the programs that CMS and other payers allow us to use with regards to case management services that we're providing to our patients. And so when this program was announced many years ago, we felt it was important to identify the patients that would be most likely to benefit from these services, and then put the tools in the hands of the people who would be delivering those services, so that we could connect the tools to the patients, to the providers that are providing the services. So this slide shows just, I guess, an overview of how we incorporated some of those technology tools into the workflows so that we could deliver chronic care management in an effective fashion. So right out of the gate in the physicians or APP's schedule, which the nurses have access to, we show how many chronic diseases a patient has. We call this a CCM score, a chronic care management score. So it's essentially the number of disease registries that a patient is in. So we can very easily see at a dashboard level or schedule level how many patients or how many diseases any given patient may have. And on the right side of the screen, using some of these other tools, risk adjustment scores, HCC coding scores, the risk of hospitalization and ED utilization, making all of these tools available, really easy to find within the clinical workflows, so that we can identify patients who would be most likely to benefit from chronic care management services. And based on those criteria, presenting the clinicians with actionable best practice advisories, or our practice advisories as some call them now, to show that this patient qualifies and might benefit greatly from chronic care management services, putting it in the point of care, in the workflow, embedding it in the workflow for clinicians to find and use. Next slide. Then, when that patient is enrolled in chronic care management, we made a decision to change the header color, so that regardless of where the patient is seen throughout our organization, that everyone who's caring for that patient is aware that this patient has a case manager. And if there are things that are outside that office visit that may need additional attention, that care manager's contact information is easily available. But bringing visibility with technology to the fact that this patient is a value-based care participant in one of the plans, but also has these extra services available to them through CCM. Next slide. Through our chronic care management program, so this is in a value-based care world, we built that program on the principle that delivering additional services would ultimately provide better care to these patients and ultimately save Medicare money. That is, of course, why CMS developed some of these programs. And in our experience, for patients who are in chronic care management, even though they are generally sicker and higher utilizers of the healthcare system, those patients, we have seen a reduction in total PMPM of about $74 per patient for those patients that we enroll in case management services through CCM. They also have a significantly lower readmission rate if they're in CCM. We're addressing quality measures, and we've done this through care team expansion. Next slide. The other workflow I'll quickly go through is for those patients who do get admitted to the hospital for whatever reason, making sure that we're doing what we can after their discharge from the hospital to prevent that readmission through our transitional care management program. Again, leveraging technology to identify those patients who are highest risk for readmission, using the readmission risk score. We have workflows in our system where case managers are identified of admissions for our value-based care patients. So at the beginning of the admission, we're starting to track patients as they approach discharge, who are those that are most likely to be readmitted, and then putting workflows and clinical programs in place for those patients. In this screenshot, you can see that this is a dashboard shot for our case manager, our transitional case managers, where they're able to see all the diseases and the admission diagnosis, as well as the patient's risk for readmission. Then, after the patient is discharged, we leverage geodata with technology from another platform, where we incorporate geodata into that discharge data and identify those patients that are highest risk, and then coordinate if they cannot return to the office for a follow-up visit, a post-discharge transitional care management visit. We do home visits for those patients with a team of nurse practitioners who are under the supervision of our medical director and hospitalist service. So we're using the technology, A, to identify those patients at highest risk for readmission, but then B, figuring out how to navigate those in an efficient fashion with limited resources to make sure that we're getting those patients a transitional care visit, even if it's in their home. Next slide. Through this transitional care management program, we are reducing readmission rates by 50%. So we're preventing about half. Our readmission rate has decreased by 50%. And we think we've been able to do that by identifying those patients who are at highest risk through the technology tools that we're incorporating into these workflows. Next slide. Through our work in the Medicare ACO since 2016, value-based care has been an integral part of Hattiesburg Clinic's trajectory, and we've had some success in the Medicare ACO space as other value-based contracts, all total saving Medicare over $82 million with our Medicare ACO plan. Next slide. Finally, from me, I just highlight again that technology has been a crucial part of Hattiesburg Clinic's journey in value-based care success, a really important piece. It's been important for us to use the tools that the EMR vendors have made available to us, but more importantly, validating that with our own data sets and making sure that they make sense in our workflows, but from the outset, making sure that we think through workflows from the beginning and leveraging those technology tools in a way that the operations and clinical teams, it makes sense to them. We can build a lot of cool, fancy things in a technology silo, but if we're not incorporating the operations and clinical teams in that decision-making process, those tools won't get their full value, we don't believe. So as I say in the last sign, in the last quote there is, the success doesn't lie in the tool, because we've got lots of tools and some of them are really cool, but in the hands of the people that are using them. Thank you.
Thanks so much, Dr. Batson. It's really helpful. Dr. Murali, over to you.
Thank you, Chris. Thanks for having me. I really am struck by the last comment that Bryan made. Ultimately, it's all about people, process, and technology. And technology is not the driver. Technology has to be incorporated into all of your processes, along with the people that are inspired and engaged to actually provide the service. So I'm a nephrologist by trade, and I serve as the CMO of medicine services at Geisinger Health Plan, a health system. Next slide, Chris. So when we think about Geisinger, we have been in existence for over 110 years. And it started with our founder who wanted to be the best in terms of the hospital services that were initiated in Danville 110 years ago. We actually believe that we are one of the best value-based ecosystems in a pluralistic environment. And now that we are integrated as part of Ryzent with Kaiser, that has expanded our presence all over the country in terms of that service. The second point is that independent of the relationship, we are one of the largest integrated delivery networks in the country. And here I mean integration from the standpoint of the financial care delivery, both the health plan as well as the clinical enterprise that works hand in hand in looking at things from a one Geisinger lens, basically looking at what is in the best interest of the patient, looking at quality, and in quality, we are really focused on outcomes caring as two important components, and with respect to worth, we are really looking at total cost of care. So when I look at the footprint, we have about 10 hospitals and 126 specialty and primary care clinics with about 25,000 employees and about 1,700 employed physicians, and in all about 3,000 providers. As I shared, we have a health plan. That number has to be updated. It's about 600,000 lives that are tied to the health plan, with a network of about 225 hospitals, all bordered in the yellow line on the map. In addition to that, we also have educational footprint, because continuous learning is something that is extremely important for us from an organizational standpoint. Next slide. So when we think about strategic priorities, managing total health, access and ease of use, as well as operational excellence are the key priorities. And in the managing total health component, we are really looking at how many at-risk lives can we manage as an organization, and how do we actually manage that utilization and total cost of care for our patients. Next slide. So I'll first focus on the ACO lens. We are proud to have been named in the Becker's Hospital Review as the top ACOs twice, and we anticipate to be named that same in this third time coming. In total, since 2019, we've saved over $225 million from the ACO perspective. That's about 45,000 Medicare lives that involve partnerships with 11 medical groups and the hospitals that we provide service in our footprint. And from the standpoint of the ACOs itself, we were among the first organizations in the first PGP demo, where we were top of the list in terms of 8 of the 10 criteria for quality. Obviously, there were 139 metrics at that point in time, then transition on to the first version of MSSP 1 and then to the MSSP enhanced. And in 2025, we'll be moving to the track E from the standpoint of MSSP. Next slide. But when I think about the total lives that we provide care for in Pennsylvania, actually rural Pennsylvania, because much of the population is between 3 cities in the state, and our footprint is all of central and northeast Pennsylvania, which is largely rural. 80% of our population is in some kind of value-based care agreement. And the savings from the standpoint of this past year in terms of those agreements are about $43.5 million. In addition, we also have been involved in the BPCI program and the next BPCIA program, which is in consideration. The savings there is about $10 million. We have a behavioral health joint venture where we provide inpatient coverage from the standpoint of behavioral health, and then provide all of the psychotherapy and other services for behavioral health in our footprint through the outpatient management end. And as we look at metrics and what we review, we are really looking at inpatient admits per 1,000 and ED admits per 1,000. Now, there are several programs that we have put in place to address those from a value-based care standpoint, whether it is our 65 Forwards program, which has reduced inpatient utilization by 15%, or ED utilization by about 45%, with an exceptional patient experience of 97%, or use of our convenient care and convenient care plus programs, which are really urgent cares on anabolic steroids from the standpoint of trying to provide the care for those patients, have improved our quality outcomes. In fact, as we compare to benchmarks, our quality outcomes are better than the quality benchmarks for HbA1cs, for hypertension, for cancer screening, as well as other factors from the standpoint of diabetes. We also have at-home programs which are embedded so that patients can be seen at home, in addition to our hospital at home programs and our relationships with FQHC, Mobile Integrated Healthcare, as well as SNF. In terms of specialties, a lot of our focus has been on what we call as a proven care and proven care recovery programs that were initiated in 2006, that is really looking at outcomes and improving them, as well as focusing on the recovery from CABG, hip surgery, spinal fusion. and monitoring sepsis, congestive heart failure, and COPD. We have other programs that are tied to serious and advancing illness, as well as getting people and their choices respected, as well as a genomic program called MyCode that is nested into this. So these are strategic priorities, and every single one of them has a huge amount of digital involvement or technology involvement for us to actually succeed. So from an organizational standpoint and our DNA, we do believe that investing in technology is absolutely critical to achieve those goals. Next slide. So when you're thinking about investing in Digital Analytics Hub, and if you look across the spectrum, it starts with focusing on managing the cost and utilization, with care management and coordination, patient experience, as well as engagement of the provider, closing the care gaps, as was nicely documented in Bryan's slides, and improving quality. And here, when we're talking about quality, we're not talking just about the 139 performance metrics. We're really focused on quality from the standpoint of outcomes, caring, and experience, and then trying to identify accurately the attribution of the population that we need to improve, and then risk adjusting and stratifying them. With our position in Ryzen, we anticipate to add more value-based platform tools, which we have initiated since 2024, into our services. Next slide. So since Bryan has talked about the different analytics platforms, I thought it would be important for us to share with you what we are doing in the space of automation and AI. So we have a substantial amount of investment in business as well as robotic process automations, basically having a computer code that generates a robot, and the robot basically works through all the different areas that we need to focus on in terms of achieving efficiency and outcomes. Next slide. So if I were to take the example of Geisinger's robotic process automation journey, it goes back to the setting up of an intelligent automation hub back in December of 2019. And we started off after the basic workup that's related to any setup of a program with a new bot at that point. And soon thereafter, COVID hit, as you know. And so in year 2020, we had about 21 automations and 20 bots that were working across 31 business lines in terms of the work that they had to do. And it involved 5 staff members. And by the time we got to 2022, the state from the COVID standpoint had grown to about 80 automations and 100 plus bots, including chatbots and low-code applications to improve efficiency. Next slide. So as these automations came on board, what I've tried to document for you is what was that saved hours in that period of time from April 2020 to October 2021. That translated to close to about 900,000 digital hours that were worked during COVID. If we were to actually operationalize that with humans, that would actually translate to 430 FTEs of work that was saved, saving the organization somewhere in the range of about 40.5 million. So I want you to recognize that we are not really looking at it from a dollars and cents perspective by just contracting, but trying to improve our efficiency as an organization by investing in the technology space so that we are improving efficiency, we are gaining value. We can use that for compliance, we can use it for regulatory elements, we can use that for audits, as well as improving patient care and experience as they go through the process of entering the institution to the point of their celestial ascent. Next slide. So here are some examples of current AI projects. We have projects related to colorectal cancer, which I'll talk about, focusing on who are at higher risk for flu and therefore getting them involved in the flu campaign, identifying where we are having unnecessary cost or waste in terms of unnecessary high-end imaging, as well as focusing on diagnostic testing and tracking those abnormalities, which I will talk about, stroke, so on and so forth. But ultimately, every single one of these projects, and we have over 400 such projects, they're all focused on improving efficiency and outcomes with a specific intervention where technology is directly involved in the care of those patients. Next slide. So in colorectal cancer, as you all know, that you need to screen about 154 patients to identify one colorectal cancer. So we have put in place a predictive algorithm where through AI, we are able to track and identify the 2.7% of that 50,000 population that is at the highest risk for colorectal cancer, and that definitely requires a screening process. And then we involve our outreach care gaps team to reach out these patients. Some of them obviously decline colorectal screening. Some are not easy to reach. But then 54% of those identified patients did go through an intervention. And what you will see is that by doing that, we are able to detect colorectal cancer 1 in 13 times as opposed to 1 in 154 times. Just think about the benefit and value to the system in terms of how many patients actually need a colonoscopy and how you manage that in terms of freed up physician time to manage patient care in a much more effective manner. Next slide. We have a system in terms of tracking abnormalities, and this is something that has gained attention for the work that we have done over the last about 5 years or so in this space. Nationally, every year, there are close to about 5 million CT scans that are performed across our country. Of those 5 million, roughly about 1.5 million of them have a lung nodule, an abnormality that's picked up in radiology imaging that requires follow-up. Now, only a small proportion of that 1.5 million lung nodules translate to a cancer or a malignancy. That's about 60,000. However, if you are trying to get an appointment for the 1.5 million lung nodules with a pulmonologist or a pulmonary critical care person, there are only about 5,500 pulmonologists in the country available. So what we did is to focus on identifying patients either by the standard referral process of being referred to this program or by having natural language processing as well as computational language processing to look through the entire record to identify those patients that had a lung nodule through the technology, or by digitally enrolling these patients into that program. And this was done for anybody who got a CT scan in our Geisinger facilities, regardless of whether they were being cared by a Geisinger physician or a non-Geisinger physician. And we had to spend time with the non-Geisinger physicians about this program and the alternative pathway here. Once we evaluated the nodule, we identified which nodules were at the highest risk for bad outcomes. And we created a protocol that was supervised by our pulmonologists and executed by advanced practitioners, where an automated message would go to every physician, primary care, to let them know that we've reached out to the patient, this is the plan, and then to the patient, inviting them for a follow-up if they were on a high risk. And we started tracking those patients with our coordinators. And between the years of 21 and now, we've had 0 missed malignancies. If you really look at that 60,000 cases that turn into cancer, 50% of those cases are lost for follow-up across the country. The malpractice claims that come up when somebody has developed an advanced cancer is substantial, and that is also a very important outcome measure that we use in terms of managing these patients. Because while it is costly to put the technology in, the savings that are generated by some of these better outcomes is phenomenally valuable to the organization. Next slide. So we are better able to manage chronic diseases. We are able to promote equitable access to care from the standpoint of identifying those that really need care versus those that don't. And we don't chalk up our systems from the standpoint of whether they're commercial, Medicare, or Medicaid. We basically identify on the disease outcome and where we need to address that. And finally, decrease the cost in terms of improving outcomes. But more importantly, what it has translated is that the time to care from the time somebody has had an image to care has allowed us to drop our waiting time from 112 days down to 8 days. And the time to the malignancy diagnosis, the median time is about 53 days. So this is a phenomenal turnaround from the standpoint of how we provide care. It's opened up about 8,000 pulmonary visits. It's identified those patients that really need a bronchoscopy and has reduced our malpractice risk substantially. So this gives you a sense of what technology can do. Next slide. So in terms of conclusion, I think I pretty much would echo what Bryan shared. It does not matter how you do it, whether it is analytics as well as all the necessary infrastructure that is required to achieve value-based care, technology is a must. But ultimately, it is the people that matter, their engagement that matters, and how they drive through the processes that matter.
Well, thank you both so much. I think that was a lot of great insight and perspectives about just the breadth and depth of the types of digital technologies, right, that can be leveraged as part of these different arrangements, depending on what their priorities are, your patient populations, et cetera. We're going to move, and I'm cognizant of time, so I'm going to take the moderator prerogative to kind of combine our panel discussion and Q&A so we can try to get to as many of our questions as we can. So just as a reminder for folks, if you have any questions for our panelists, please use the Q&A box widget. Submit your questions, and I'll do my best to get through all of them. We also had a substantial number of questions that were submitted ahead of time. So with that, first off, I think we covered a lot of great successes as part of this work, but I think, as you know, it takes a lot of effort and time really to get to that point. Can you all talk a little bit about some of the potential obstacles that you all face, whether it be clinical, administrative, logistical, and maybe some of the key solutions that you all were able to put in place to help overcome those? Dr. Batson, why don't we start with you, and then we'll get over to you, Dr. Murali.
Sure. I'll circle back to kind of my comments on with regards to integrating the technology into practical day-to-day workflows. If we built the technology kind of in a silo separate from what was reality in the workflows, I don't think they would have been as well adopted or well used. Dr. Murali's comments regarding, practicing in rural America certainly resonate with me. In Mississippi, of course, we have the lowest physician to population ratio in the United States. So these technologies that we're using really helped us leverage the skill set of people at the top of licensure and augment the care that they're able to deliver. But out of the gate, I don't think we would have been successful had we not incorporated the clinical and operations teams in the decision-making, in the build, as we built these tools. So that was a big hurdle for us that I think we navigated nicely, but I think we can always do better on that, and we continue as we roll out new things to focus on incorporating the end users with the technology as we're building it out.
I completely agree with Bryan. So co-developing the models with the physicians and the system is an extremely critical phase that is necessary for addressing the concerns that you have. So I think for us in a pluralistic environment, there's always a question of trust, right? So when you were to put in a technology like STARE, which identifies patients who are cared for by non-Geisinger physicians as well as Geisinger physicians, the worry always remains, are you going to steal my patient, right? So it is extremely important that we are upfront, we are transparent with the process, they recognize how the process works, we educate them and get them to trust that process and deliver on it. And then as they see improvement in the performance, they are one of the first people to actually support the process. So you asked me a question as what was difficult. I think getting that trust was the most difficult part. Getting the primary care physicians to accept that there's an alternative pathway where a nurse practitioner is going to reach out to the patient and is going to reduce their malpractice risk was an important factor from our standpoint.
Thanks so much. So the next set of questions, we've received a few of them, is just really understanding the breadth and depth of potential technologies around different settings. So we've had questions around how might this work in FQHCs and critical access hospitals, for independent physician groups. How would you all kind of look and navigate those different kind of settings? What kind of solutions might work best to prioritize? How do you navigate the potential need for limited resources, time, right, for training, and also understanding that there's influence as well in terms of the access potentially from patients or even the digital literacy of how to potentially access some of these solutions. So can you all kind of pick and choose from that group and provide some perspectives there?
Sure. I'll start. Obviously, we're an independent group, so we're using these tools in an independent group. But for me, the solutions, we extend our EMR to a large group of FQHCs in our area, and we work alongside them in caring for the populations in our communities. And these CCM tools, remote patient monitoring tools, are used whether they're in our independent organization or the FQHC environment. And we build the tools out that are kind of in an agnostic way to the setting of care, recognizing that there are variabilities even within our organization and the populations we serve. And we spend a lot of time when we bring new physicians into the organization and other members of the care team in training around these tools. We extend that training also to the providers who are working outside of Hattiesburg Clinic in an FQHC or a hospital environment, so that there's a lot of visibility and awareness of these tools, like that orange banner. That orange banner follows the patient no matter where they are. And that means that patient has a case manager RN working alongside them to help them with their needs. That would be my answer to that, the list of questions, Chris.
I actually vehemently agree with Dr. Batson on that. There's no question in my mind that this requires a lot of collaboration, and the relationships are not transactional, right? So you're really looking at a transformative relationship, which is based on transparency, simplicity, and flexibility. So those are the elements, whether it's an FQHC, whether it's an independent group, whether it's part of an ACO, whether it's outside an ACO, those pieces are the drivers from the standpoint of getting that necessary traction.
I'll sum it up again, just in echoing what Dr. Murali says. It's value-based care and population health is a different form of healthcare delivery. And while the rules or codes or the ways that we go about it may be different in an independent organization versus a hospital versus an FQHC, the themes are the same of how to deliver better healthcare in a coordinated fashion across populations. And so if we build the tools with that in mind, using technology, it's translational across all those environments.
And then the other point, Chris, I think which is very critical to remember is that how many people does it really require you to convince for you to get the traction across the organization? And I use the square root formula there, right? So if you have 100 physicians involved and you need to get them all educated to understand the initiatives, you start with 10. So once you get to that square root number, all you need is that 10 people to recognize the value, and that in itself will be broadcasted and cascaded to the other teams about that benefit. So for example, I do know all the things that Bryan and his team do, and I reach out to him for advice because I know that there are things that they do phenomenally well that we can ape and copy, and we exchange information. So that's an important factor that will actually get us the steam that's required to move towards value-based care as a country.
So we've got a couple questions, and I'm trying to combine to save time as best as possible. But can you do a little deeper dive in terms of some of the reactions, both from the clinician side of things, right, in the back end, but also from the patients when it comes to some of these technologies? How have they responded positively or potentially negatively, and how you've kind of navigated those perspectives to get to that exponential engagement, Dr. Murali, that you mentioned? I think that's a critical piece, right, is to ultimately get to the intended value of implementing some of these solutions.
So I will share with you, I got that question, Chris. Thank you. I will share with you my personal experience with a 94-year-old lady when we initially started our hospital at home program. The refrain I heard was that patients are not technologically savvy. They're unlikely to use the technology outreach that is going to be embedded to provide their care. And so in the Midwest, where I was initially working, it was absolutely a rural atmosphere. And when we started the hospital at home program, I realized that there were my grandparents and my grandmother and others who are extremely savvy in using the iPad and what's required for remote patient monitoring. So it's a question of educating folks and getting them to see the value. So the way we propagated that is to get people to recognize that their care is equivalent, and in fact, their outcomes are better if they were to actually get that hospital care at home as opposed to in the hospital, right? Because your risk of infection is reduced. It's the Cadillac of service. You have a physician and a nurse visiting you at home and providing the service. Pretty much all the infrastructure is built in, so they don't have to go back and forth. And for the family, it becomes convenient. So we kind of focus on those elements to get people to recognize the power and the value of these programs.
I'll add, just from on the physician or provider side, the governance around the sharing of information, really crucial to all these tools, is making sure there's a full understanding of them as we begin rolling them out, and making it less about being rolled out from the top down, but providing the tools and letting the physicians and other care team members pick which ones that they think make the most sense in their local environment. So we build the tools and again, putting it in the hands of people that feel like they can use it. On the patient side, I think I look back to 2020 really and think through all the terrible things that happened with COVID. One of the positive things is that our patients became much more comfortable in using technology with their healthcare. And we leveraged that familiarity and comfort level going forward. Our COVID clinic, if you will, only accepted patients through the drive-through or in person electronically, and we did case management services through electronic communication. And so through that awful time of 2020, we pivoted from that. As our patients got more comfortable with this, we just built upon it and didn't let that momentum slow.
That's a great point, Bryan. I do agree. I'm tickled about something. So on one end of the spectrum, you have a little child going into a pediatric, outpatient setting, and they had books in the pediatric outpatient setting for this kid to read, right? And my wife was observing, because she's a pediatric neurologist, and they could see the kid swipe left because they had not learned how to turn the pages, because they had used to using the phone or the iPad. And then on the other extreme of the spectrum, you have this 94-year-old grandmother who was unwilling to let go her iPad after her 30-day of her hospital admission stay happened. So we finally had to get her philanthropy gifts to make sure that she had the iPad and the internet access. So you can't lose steam of the technology and what it can provide in terms of care and outcomes for our populations.
Yeah.
Fantastic. So we also received a question around, it's great to be able to invest and get these outcomes, but ultimately they need to be financially sustainable over time, right? And you all showed some financing outcomes based on some of these programs, but how do you all ensure these investments in these technologies are enabled or allow you all to succeed in achieving your overall financing goals?
Yeah, great question, and a very real question that we face as we look at all these expensive technologies. And, I was looking recently at our budget for this year and how much our technology budget has increased over the last 5 years. For us, and the two programs that I highlighted, our philosophy around the quality management department that is delivering CCM and TCM and other services out of that department, they're providing services that are fee for service and reimbursed services. So the philosophy is we're going to build that department at a base, at a minimum, it will be budget neutral. But in order to do that department in an efficient way, it means finding the right patients for the right services and connecting the right patients with the right tools. We couldn't do that without technology. But then we're delivering, for lack of a better term, fee for service services like CCM and TCM and annual wellness visits and on with these tools in a way that they're covering the costs of the people and the technology that are needed. But then on top of that, we would not be able to generate the shared savings in our value-based contracts without these tools, without the tools that are used in the quality management population health department. Using those tools in a way that is forwarding our journey in value-based care and then providing us with additional revenues to further invest in that infrastructure. That said, it is certainly not, it is an expensive route, but it is an investment toward a strategy of population health and improving healthcare delivery through a value-based care lens.
I agree with Bryan. There's nothing much more to say there. Amen.
Fantastic. Well, I know we're getting short on time. Try to throw in one. So we did get a couple questions as well, not just about engagement with the individual team members, but creating or better enabling that true team-based care approach between, and I know Dr. Murali talked a little bit about the PCPs and the other specialists. How have you all been able to use technologies to better engage those different members of the care team to help achieve your value-based goals?
Yeah, so I would like to say we need more, but we have been able to engage pretty effectively from the standpoint of what is available at this point in time. Complex care coordination, which is something that Bryan was talking about, is something that is very critical. So how do our case managers recognize that there is a high-risk individual who has come into the ED, and how do they actually get the right specialty leaders involved in providing the support so that that patient is not admitted to the hospital? That is all technology-based, and that is embedded, and we reach out to do that. Or on the other hand, if you have a physician who does not recognize the value of care coordination, transitions of care, all of that work that Bryan's team has done in Hattiesburg Clinic, it is very easy to show them the data. All you have to do is to bright spot patients that they are providing care for and showing them how many times they came into the ED for care or were admitted in the hospital. And we've had conversations with other providers to show that some of their patients had come in 94 times to the ED. In other words, every other day they were in the ED, right? So once they see that data, people jump on and say, tell me how I can help. So that's really how we've gone about the process. But Bryan, I'm sure you've done something similar.
Yeah, it is about coordination. And I think using the tools in a way that those skill sets of the specialist are very, very important, but they're different than the skill sets from our primary care doctors and the case managers and the nurses that are supporting those teams. So it's about making the best use of all the resources and coordinating them in a way that makes the most sense, but leveraging technology so that everybody on the care team is working at the highest level of their expertise and training, because everybody on that team is a crucial piece if we're going to have success in this value-based care world.
Fantastic. Well, not surprisingly, we haven't been able to get to all the questions that was submitted beforehand and during the session. I really appreciate everybody. Just to help us kind of round out the session, I want us to kind of put on our future thinking cap. And each of you talk a little bit about what you all might be considering in the future, either additional expansions of your current capabilities or perhaps even additional technologies that you might be considering. And then just wrapping up how that might impact your kind of future look of value-based care, digitally enabled value-based care kind of moving forward. So Dr. Batson, why don't we start with you, and then Dr. Murali, we'll end with you.
Sure. In the value-based care space, I think we know there's still so much opportunity for us, at least in our area, with regards to the post-acute space and pharmacy and ensuring better medication compliance. So we're really looking a lot into some additional technologies that can help us identify medication noncompliance or those patients who are more at risk for medication noncompliance. That I think is a crucial piece of preventative. Prevent the admission, prevent the outcome, prevent the deterioration. Further up in the chain of disease decline. Then on the back end, the post-acute management, how can we do a better job? And the great work being done at Geisinger and other places with hospital at home work. So we're really putting a lot of thought in that space. But then last thing I'll add, just other technologies, is really thinking again about the quadruple aim. And if we're making this transition into a value-based care space effectively so that we're providing better care, keeping the physician and the members of the care team that are so crucial to this value-based care, keeping them engaged and satisfied and joy in their product of work, that we're coming and using technologies that are bringing them more satisfaction in that job. Lots of work has been done around ambient AI, automated responses from in-basket draft, chart summaries. We're doing all of those things and learning a lot with those, because our thought process is if we can eliminate 15 to 20% of work for everybody on the care team and automate some of that, then that is time that can be better spent on things that only they can do. That's where we're spending a lot of time and focus right now.
Fantastic. I think from our standpoint, we're really looking in terms of next generation tools that are available from the standpoint of evidence-based care, so that's available to the physician so they can actually manage those patients without reaching out to a specialist for that. So that's one thing that we have been focused on. And then, as Bryan mentioned, a lot of investment has gone into ambient technology, ambient dictation, as well as inbox management, because that burnout component and the trying to reduce that burden and making it clinically simple for a physician is an extremely important component that we have been focused on in terms of that. And then finally, in terms of the right place and right time, trying to identify how to segment out the populations in such a fashion that we can actually manage for rising risk. So not just from the standpoint of chronic care diseases, but also identifying rising risk by using our proven care technologies, as well as using the Charleston Comorbidity Index, Epic End of Life Index. So on multiple different tools that we use to segment populations to make sure that we are able to provide that care. So those are the areas that we are looking. But this is going to be a never-ending process, and we're going to continually improve and try to make things better for our patients, and ultimately making better health easier for everybody in the community.
Well, that's a great way to end this discussion. Just want to thank you both so much again for taking the time to share your expertise and experience with our audiences. It's invaluable, and I think it's really insightful to be able to really understand the breadth and depth of the way digital technologies and solutions can help with value-based care. So with that, I'll pass it over to Alec to help close this out.
Thank you folks so much. For additional resources and guidance to support your physicians and staff, including those on digitally enabled value-based care, please visit the American Medical Association website or stepsforward.org. We hope to see you again soon. Have a wonderful day.